Congenital abnormalities in orthopedics. General features: defects in the development of body form or function since at the time of birth. Localized and generalized. The incidence is difficult to determine, approximately 3% at birth and 6% at 1 year of age. It is not unusual for 2 or even more abnormalities to coexist. The etiology consists of genetic defects, environmental influence, or the combination of both. For the types of musculoskeletal abnormalities, it involves localized abnormalities, which disturbance of normal growth and development, such as aplasia, hypoplasia, dysplasia, hypertrophy, duplication, arrested at development, or the abnormalities in the joints, such as unstable or dislocated, failure, or segmentation. Secondly is the generalized abnormalities. It is the defects of epiphyseal plate growth or imbalance between bone deposition and resorption, or congenital generalized joint laxity or amyoplasia congenita. Principles and the method of treatment. Firstly is the longevity. Secondly is the knowledge of significance and prognosis of congenital musculoskeletal abnormalities. For the localized abnormalities of the lower limb, it involves the foot, the long bone, the knee, the hip, amputation in the lower limb, or hypertrophy. For the foot, toe deformities, localized overriding of the fifth toe, or congenital varus of the small toes. For the localized overriding of the fifth toe, it is a result from dorsal subluxation of the metatarsophalangeal joint, which associated with shortened extensor tendon and tightness of the overlying skin. It is sometimes named Z-plasty. For the congenital varus of the small toes or the curly toes, it is relatively common, particularly in the third toe, usually corrected spontaneously. Other type of toe deformities is metatarsus primus varus, or the deformity of the first metatarsal in relation to other 4 metatarsal. The other is metatarsus adductus. It is the adduction of all metatarsals in relation to hindfoot. Clubfoot. It is a combination of forefoot adduction and supination through metatarsal joint, heel varus through subtalar joint, equinus through ankle joint, medial deviation of the whole foot in relation to the knee, results partly from angulation in the neck of the talus and internal tibial torsion. Assessment of the severity of clubfoot is by feel of flexibility. It could be either mild, moderate, and severe. The incidence of clubfoot is 2 per 1,000 live births. Known genetic factor about 10%. The etiology and pathology handlement suggest neuromuscular causes or chiral pathological anatomy. The differential diagnosis should be distinguished from positional equinovarus, which results from intrauterine position, and teratologic type associated with spina bifida or arthrogryposis. The treatment is first to reassure the parents, and the second is for the early treatment. It is ideally started within the first week of life. First is to plaster cast applied for weekly for 6 weeks, and may be continued or shift to Dennis Brown Clubfoot Plain. It is either Dennis Brown or AFO, worn day and night during ensuing 3 months, and worn at night for at least another 1 year to prevent recurrence. Straight last or out-flare boots are used for a day wear until the child is 3 years of age. The assessment of completeness of treatment requires specific radiographic. Approximately 40% will respond satisfactorily, while the other 60% are resistant. Less than 5 years of life, capsulotomies, tendon lengthening, tendon transfer are effective. Whereas for children more than 5 years of life, require arthrodesis of the subtalar and metatarsal joints, but best deferred until the age of 10. Talipes Calcanovalgus. One or both feet maintained in the dorsiflex and inverted position. Results from intrauterine position, and it is comparable to positional equinovarus. Daily passive stretching will spontaneously correct the deformity. For the congenital plantar flex or vertical talus, it is uncommon but serious congenital abnormality. The talus is rigidly fixed in a position of extreme equinus, whereas the forefoot is dorsiflex and inverted, results in convex sole, confirmed with lateral radiograph of the foot. Usually require operation. Tarsal coalition. Any tarsal may be congenitally joined together by bridge or bar. At early, it is still cartilaginous. In adolescence, it will be ossified. Personal spastic flat foot usually is rigid and painful, usually undetected during the first 10 years, after which secondary degenerative arthritis of talonavicular joint causes painful foot or the shuffling gait. Operative excision of the area of coalition for younger children. For older children, combine subtalar and metatarsal arthrodesis. Accessory tarsal navicular ostibialia externum usually become painful, need excision. The long bones. Pseudoarthritis of the tibia. It is rare. It is characterized by the fail to grow normally in width, angulated in lower third, anterior bowing of the leg before birth. It is often associated with neurofibromatosis. It requires special techniques of bone grafting. Free vascularized autogenous bone graft using opposite fibula. Hypoplasia of the long bones is rare but very deforming. May involve fibula, tibia, or femur, commonly called congenital absence of particular bone. For congenital hypoplasia of the fibula, there is an abnormally short tibia in the anterior bowing. Soft tissue operations are helpful but require built-up ugly foot brace required. When severe, sometimes amputation and prosthesis is needed. For the congenital hypoplasia of the tibia, reconstructive operation seldom satisfactory. Usually, disarticulation of the knee is indicated. For congenital hypoplasia of the femur, it varies in degree but usually severe. When built-up boot is inadequate, use prosthesis. The knee. Dislocation of the knee. It is uncommon and often a manifestation of arthrogryposis. Anterior dislocation of the knee joint usually require operative reduction and lengthening of the contracted capsule and muscle on anterior aspect of the knee. Dislocation of the patella. Hypoplastic, lateral, early soft tissue operation involving quadriceps mechanism. Discoid lateral meniscus. Lateral meniscus is thicker, somewhat disc-shaped, like adequate peripheral attachment posteriorly. Loud clunk during extension of the knee. Usually produce pain in childhood. If there is an inadequate peripheral attachment and it is irreparable, then we should do excision. Leads to degenerative arthritis of the lateral compartment of the knee. The hip. Developmental coxavara. It is a localized congenital defect of ossification in the femoral neck, mild shortening of the lower limb, and limitation of passive abduction of the hip. There is a positive of the Trendelenburg sign, some relationship with congenital hypoplasia of the femur. The most effective treatment is valgus subtrochanteric osteotomy of the femur, ideally before marked varus deformity has developed. Developmental dysplasia of the hip, or DDH. It is not obvious at birth and requires high degree of suspicion. Therefore, we should always examine the hip joints of every infant. Unless treated early and well, it inevitably leads to painful, crippling, degenerative arthritis of the hip. Dislocation results from femoral head being completely outside the acetabulum. Subluxation is when the femoral head riding laterally and proximally but still in contact with part of acetabulum. Developmental dysplasia of the hip. The incidence of DDH is 1.5 in 1,000 live births. It is usually bilateral. Girls more often than boys. Positive family history or history of breech presentation. Swaddling is associated with higher incidence of DDH. Congenital muscular tuberculosis or metatarsus adductus have higher incidence. The etiology and pathology of DDH involves the developmental displacement of the hip. Is the end result of combined genetic and environmental factors. In utero, the hip is constantly in acute flexion. 1 in 80 exhibits hip joint laxity. At birth, is dislocatable. Spontaneously becomes stable within the first 2 months. If it is maintained in extension, it tends to remain dislocated or subluxated. Secondary changes, such as dysplasia of the acetabulum, increase in the normal femoral neck anteversion, hypertrophy of elongated capsule, contracture and shortening of adductor and iliopsoas muscle. Diagnosis and treatment vary greatly with each groups. The general principle of the treatment is to gentle reduction with the hip in a stable position until the various components of the hip are well developed and the hip has become stable. For DDH in birth to 3 months old, it is the most important period of greatest opportunity. However, the abnormality is never obvious. We always have to seek out for Barlow test and ortholany test. Re-examine physically and radiographically at 4 months of age. Limitation of passive abduction of the flexed hip. Ultrasonography is superior. It is indicated for infant younger than 6 months. Positive clinical sign and family history and history of breech presentation. After 6 months, plain radiograph is preferable. The treatment involved a gentle reduction followed by maintenance of the hip in stable position of flexion and abduction using French-cow pillow splint. Alternative from French-cow pillow splint is the pelvic harness. Period of 4 months protection is needed for the capsule to become tighter, and it also should be regularly assessed. DDH in 3 to 18 months old. Adduction contracture is more marked. Unilateral dislocation results in shortening of the thigh is most apparent when the hip is flexed and the level of the knee is compared. Using the Galeazzi's sign should also be checked with telescoping maneuver. Excessive slope of the ossified portion of the acetabulum, delayed ossification of the femoral head, varying degree of upward and lateral displacement of the head of the femur. The treatment involves preliminary lengthening of the tight abductor and hamstring by continuous tape traction for a few weeks. Subcutaneous adductor tenotomy, followed by gentle close reduction of the hip under general anesthesia. After confirmation using radiograph, maintain in hip spica cast in stable position of marked flexion and only moderate abduction. Too much abduction could cause AVN of femoral head. It is in 80% patient, it is usually good prognosis. However, if close reduction fail, consider open reduction. iliopsoas muscle release, and capsular repair by anterior approach. DDH in 18 months to 5 years old. The secondary changes are more severe and less reversible. We should always check for the typical limp, Trendelenburg sign, and waddling duck. The treatment: longer period of tape traction, subcutaneous adductor tenotomy, femoral shortening for children older than 3 years. Likelihood of obtaining perfect closed reduction is less. Open reduction, tight iliopsoas, and elevated joint capsule. The main problem is to maintain the reduction. Salters innominate osteotomy, resulting in 87% good after 33 years. DDH in older than 5 years old. Secondary changes are more marked and their reversibility is so limited. Attempt at reduction is deemed unwise. Palliative and salvageous types of operative procedures. Amputation in the lower limb, less common in the lower limb than in the upper limb. May be as minor as absence of single toe or as major as complete absence of both lower limb. It is often associated with congenital annular constricting band, early fitting of prosthesis, no excuse for makeshift prosthesis. Hemihypertrophy. The structure of each half of the body is perfectly normal, but asymmetrical. The resultant leg length discrepancy, surgical epiphyseal arrest at appropriate age, or by surgical shortening of the femur at the end of growth. Wilms tumor develop in 2% of children with hemihypertrophy.